Hi, this is a quick lecture on how to detect pulmonary emboli using ultrasound. I want to thank Thomas Love and Adam for a couple of the images and insights that they've given me into this. And essentially this is a brief lecture on how to look for DVT and what cardiac changes you see on echo when people have a pulmonary embolism. The most important thing that we need to remember as clinicians when we're using ultrasound with limited education is that we are clinicians, and our ultrasound information is useful, but it's limited. They're going to be things that we haven't heard of or things that we haven't seen that we may see and not be able to interpret. So it's really important that what you're seeing makes clinical sense. This is another tool to our armamentarium, but it's not everything. So your clinical suspicion is really important. History and examination is really important, and you've got to be directed by your clinical impression. So if you thought and you're sure they were having a pulmonary embolism and it looks like there's a pericardial effusion, does it make clinical sense? Could it be a pericardial fat pad? And if you're not sure, it's important to get it checked. So when you're doing an echo, you think about what is your primary question with each view, whereas an echo technician who's doing a formal echo will be getting the best pictures of every single view, looking for everything. But we're thinking, what is the question? And the question that this lecture is going to look at is, could this be a big pulmonary embolus? Could this be a PE that's so big it's made this person hypotensive in the peri-arrest situation? And you can start by looking in the legs for DVT. You can look at the IVC to see changes there. You can look at the heart, and you can look at the lungs, and we're going to go through each of those very briefly. We all know how pulmonary emboli happen. You start with a DVT. It's usually in the deep veins of your legs. It can be in the iliacs, common femoral vein, superficial femoral vein, popliteal veins, occasionally in the upper limb or neck veins. When someone's had a PE, they may not have any evidence of DVT, but sometimes you can see thrombus still in the veins, and typically where a vein will normally compress when you put ultrasound pressure on it, when it's full of clot it doesn't, and sometimes you still see echoes and visible clot within the lumen, although fresh clot's often hypoechoic, but it's always non-compressible. Obviously with a PE what happens is a bit breaks off from the DVT and it floats up the venous system through the heart and gets stuck in the pulmonary arteries, and that's when real mischief begins. And very occasionally you can actually see DVT as it floats up through the venous system before it gets lodged wherever it gets lodged. So looking in the IVC, you can see thrombus occasionally, and we'll show you how to look in the IVC. You tend to look just about 2 centimeters distal to the hepatic veins, and you look for the size of the IVC and its respiratory variation, and other lectures will discuss that. So as I say, occasionally you can see thrombus. If there's been a pulmonary embolism and you've got really high right-sided pressures, what you're going to get is a round IVC, and normally it's more teardrop shaped or even flat in a hypovolemic patient. You're going to get a round IVC which doesn't change with a respiratory cycle. A slight change in intrathoracic pressure and it won't collapse, whereas with a normal euvolemic patient the IVC won't be quite round and you will get some respiratory variation. So a big round IVC. Next we go up to the heart, and you start by looking at the right side of the heart. You look at the right ventricle. Is there thrombus in it? And occasionally you can see thrombus floating through the right atrium and right ventricle. Normally the right ventricle is about 60% or 2/3 of the size of the left ventricle. Is the right ventricle big and distended? Is the right ventricle working? And if you watch the tricuspid annulus, you can see whether the right ventricle is working or not, because what happens with right ventricular contraction is that the tricuspid annulus moves towards the apex, and with each beat you get shortening of the right ventricle. When the right ventricle doesn't work, that shortening stops, and we'll be able to see that in the normal and abnormal videos that are coming up. The other thing that we look at is McConnell's sign. Now, that's not incredibly sensitive nor specific, but when you've got an acute PE and the right heart's not working, you can see that the right heart is dilated, it's not contracting properly, but often the very apex of the right ventricle still contracts relatively well, and that's called McConnell's sign. And finally, people with chronic cor pulmonale have right ventricular dilation and distension, and sometimes it doesn't work as well, and that can be confusing. And so you need to think again as a clinician, has this patient got chronic lung disease? Do I think this could be cor pulmonale? And one of the things you look at is for right ventricular hypertrophy, and you get thickening of the right ventricular wall. Instead of it being very thin, you get a thick wall. During an echo, you sometimes can see the pulmonary artery, you can see the pulmonary valve and the pulmonary outflow tract, and you can follow that and occasionally even see its bifurcation, and you may see a saddle embolus there once you get quite good at echo. Then look at the left ventricle, and this is all from relatively similar views, or the same views in fact. The left ventricle, so you've got a big pulmonary embolus which is blocked off the pulmonary outflow tract. Suddenly there's not enough blood getting to the left ventricle, but there's lots of adrenaline. And so you get a really well-functioning hyperdynamic left ventricle which hasn't got enough fluid, so it's empty. So you get a big dilated right ventricle and an empty hyperdynamic left ventricle. The interventricular septum is another key place to look at with big pulmonary emboli, because suddenly, instead of having a low pressure right system and a high pressure left system, you've almost reversed the tables. And so where you've normally got on a cross-sectional view or a parasternal short axis view a round left ventricle, the interventricular septum between the two is really flattened, and you end up with a D-shaped left ventricle in cross-section. And when the left ventricle contracts in systole, instead of that D portion of the left ventricle moving inwards as the rest of the ventricle does, it actually moves outwards, because as the pressure within the left ventricle increases, that ventricular wall in the septum moves towards the right ventricle, and I'll show you that on images. So you're looking for a flattened, displaced interventricular septum and a D-shaped left ventricle. Finally, you can look at the lung, and occasionally you can see a pleurally based wedge-shaped infarction. That can be useful. It often doesn't develop immediately, and it's more like the thing you put in fancy lectures like this, rather than what we actually look at by the bedside in a critically ill patient. Now, we always put everything together. You get all the views you can as well as you can, and from that you make your assessment. But I think the parasternal short axis, where you get that round view of the left ventricle, is a particularly useful one, and the other one that's particularly useful is the apical four-chamber. But always still try and get your subcostal view and your parasternal long axis. Now, how good is ultrasound for pulmonary embolism? Unfortunately, it's not very good. I think if someone is critically ill and they've had a pulmonary embolus that's big enough to make them hypotensive and shocked, you're likely to see echo changes. But I haven't actually seen literature on that specifically. Generally, echo for PE is only about 40 to 50% sensitive and 90% specific. It all depends. If you see the clot, then you know that you're going to be right. But a normal echo, and in fact just last week I saw a patient who had a saddle embolus, who had a normal echo. She wasn't hypotensive, but she was tachycardic and hypoxic, and her echo didn't show any stress, which was unusual, but it can happen. And certainly echo can't rule out small PEs. So thoracic ultrasound, so transthoracic as opposed to esophageal, has been quoted as being 74% sensitive and 95% specific for PE, and looking for DVT is also very variable. it may have broken off completely, it may have been from the iliac vessels, and you may not see anything. But if you do see a DVT and it fits in clinically, it probably is a PE. If you do see right-sided changes and it fits in clinically, it probably is a PE. So whilst you are not so good at ruling things out, in those critically ill patients, if you can rule it in, it makes a huge difference. Okay, now this is a subcostal view of someone who's had a pulmonary embolism, and you can see here is the right ventricle, which is dilated. Now this is the tricuspid annulus which we're looking at, and we watch it. Normally it would move this way about 2 centimeters with each cardiac compression. But you can see this dilated right ventricle and right atrium really not working very well, whereas this left ventricle is pumping, and it's actually kissing. You can see the two sides of each wall touching each other, and it's small and empty. So an empty left ventricle, a big full right ventricle that isn't working very well, and that's a subcostal view of what a pulmonary embolus can look like. This is my favourite view. This is the parasternal short axis view, and you're used to now seeing a round left ventricle and a small crescent shaped right ventricle. Now all of a sudden this patient's had a big PE. You can see that the right ventricle has got very big. The left ventricle is small, and it's hyperdynamic and empty, and sides are almost kissing. This is the interventricular septum, and this is the D shape that I'm talking about. You can see instead of this being round, this is flattened. Okay? So the interventricular septum is flattened because of the raised right-sided pressures. The other thing that I think is really important is that with systole, watch this bit here and watch it go in. Watch when it goes in. So it's going in. When this bit goes in here, or in fact all of the non-interventricular septum contracts in systole, this bit actually goes out. Okay, and that's called paradoxical septal motion. You need to concentrate and watch it. When this bit goes in, this bit goes out. And that's because all of a sudden during systole you've built up the left-sided pressures, and that can make the septum actually, the pressure increases and the septum moves out. So paradoxical septal motion. These are some of Adam's pictures, and are very, very useful, and I'm grateful for them. Again, this is the parasternal long axis. You may not say that there was anything abnormal on that at our level of expertise. Here's the short axis where you can see a large right ventricle. This is the apical 4-chamber view, and I think this is the one that you'd actually get a big suspicion on this view. Suddenly the right ventricle, instead of being small, you'd sort of expect it to come down here, is the same size as the left ventricle, and I think that's a key. If you think the right ventricle is the same size as the left ventricle, then it's big. If you look here at the tricuspid annulus, usually, as I said before, this moves up with each systole about 2 centimeters towards the apex, because the right ventricle shortens with each contraction, but it's not. So we've got a big dilated right ventricle that isn't working well. This isn't contracting, and this little bit is working relatively well. That's McConnell's sign. That's the apex. And so if you've got a patient who's had a swollen leg and then has suddenly collapsed with hypotension, shortness of breath and hypoxia, this confirms that firstly it's definitely not hypovolemia. It's definitely not a tamponade. The LV is working relatively well. It's not a terrible LV. It's not hypovolemia, and it is likely to be a pulmonary embolism. Here's another one. On this one, on the parasternal long axis, you see that the left ventricle is hyperdynamic and working well. The right ventricle isn't working so well. And again, in parasternal short axis, we've got a big right ventricle, and there is slight paradoxical septal motion here, but a D shape not quite as beautiful as before. This is an interesting one, and again, as you get better and better at echo, you'll see more and more. We'll try on the normals to show you the pulmonary outflow tract. This is the pulmonary outflow tract, which you see in the parasternal short axis when you angle the probe up towards the base of the heart, the aortic valve. Here is the pulmonary outflow tract. here is the right main and the left main pulmonary artery, and this is a bit of a clot stuck in a saddle embolus, which you see very rarely and people record for posterity's sake. There it is again. Here, the left ventricle is hypodynamic. You can get a sense that the interventricular septum is pushed from right to left. The tip is working well, but here actually there's reasonable, you can see that tricuspid annulus moving up. The right ventricle isn't desperately bad, but you can see clot, so you know it's a PE. This is what it looks like with cor pulmonale. This is a patient who's had raised right side pressures for a long time. And here's the right ventricle. You can see its wall is actually thicker than the left ventricle, so it's hypertrophied over time. You've got a big, high-pressured right atrium, which has got this interatrial aneurysm formation and pressure with displacement of that towards the left. You can see that the interventricular septum is displaced, and so this is cor pulmonale. Then on to the IVC. You can see here this is inspiration and expiration, and it's a big IVC, okay, it's over 20 millimeters, and it doesn't change, it doesn't collapse with inspiration. So this means that there are high right-sided pressures. So just to go through it again, you're looking for DVT distally, a non-compressible, a non-collapsing big IVC, a dilated, non-contracting right ventricle which may have McConnell's sign with the apex working well, a D-shaped interventricular septum with paradoxical septal motion, and an empty or hyperdynamic left ventricle, and you may see clot in the pulmonary artery. There is a big dilated IVC, not collapsing with each inspiration. Now this is a lung view, and there will be a bonus lecture put in on thoracic ultrasound. This is the chest wall here, here's lung, and here is a very small infarct that you can see in the pleura. It's fairly non-specific, much easier when it's in blue, but to be honest, I wouldn't go looking for it acutely. When you're looking for DVTs, it's important that you understand the normal anatomy of veins, the normal flow, that they're compressible, you understand augmentation, and there is a relatively quick approach. One thing that we often do, we know that veins are compressible. So when they're full, when you press with the ultrasound probe, the artery, which is under higher pressure, unless someone's actually in arrest, doesn't compress very easily and is round and pulsatile, whereas the vein compresses with each beat. So if you've got an artery, it looks like this, shh, 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 and when you compress on it with the probe, it might go like this, shh, shh, shh. The vein, on the other hand, may look like this, although it depends. If you've got high right-sided pressures, it might look like this, or it might look like this. And then you press on it with a probe, and it will collapse nicely at a pressure which doesn't collapse the artery. So one of the key things that we look for when we're looking for a DVT is compressibility with the ultrasound probe. The other thing that we can look at is you can put colour or Doppler onto the vessel, onto the vein, and you can squeeze distally. So you can imagine if you're looking at your femoral vein and you squeeze your calf, you should get a sudden increase in flow unless there's a blockage at that site or below the vein. So we're looking for compressibility, we're looking for augmentation, which is where you squeeze the calf and you get an increased flow, and you can look for echogenic material within the lumen of that vein, and a lack of flow. And the 4-point compression approach is a relatively quick and effective one. You don't want to spend half an hour looking for a DVT in a patient who's critically ill, but if you just look at the level of the groin at the common femoral vein and at the popliteal vein, there's a relatively high chance that you will find a DVT if it is present. Having said that, obviously it may have broken off. So an acute DVT, the vein often is dilated, it's non-compressible, there's no flow in it, and you you do tend to see echoes within it, but very acutely, acute clot can be hypoechoic and not be obvious. Chronic DVT tends to shrink and becomes more echogenic, and you may have a rim of flow around the DVT. So this is compressibility. Here is a normal artery and vein, and when you squish, the artery stays and the vein disappears. And we'll see that live. When you've got clot in it, this is the popliteal artery and popliteal vein. This is with compression, not with compression and with compression. When you've got clot, it looks grey and it doesn't squash. Here again, this is acute thrombus. We've got an artery and then a big venous clot which is distending the lumen as it does acutely, where there's no flow, where there's no augmentation, where there's no compressibility, and then you're sure that there's clot there. So finally, echo can be very useful with confirming a pulmonary embolism, but most importantly, it's not good at excluding a pulmonary embolism. If it's big enough to cause hypotension and peri-arrest, you'd expect to see echo abnormalities, but you really have to fit it into your clinical picture. Another important thing is when a patient is in full arrest, the right ventricle is often dilated. We've poured in a litre of fluid, we've filled up the right side, or the right side of the system has gradually filled up with blood as we've done CPR, and the right ventricle may often be dilated, and that doesn't necessarily mean it's a big PE. So if someone's in full arrest, I wouldn't rely completely on the fact that a dilated right ventricle. In the peri-arrest situation, much more useful. And finally, like all of ultrasound, it all comes down to practice. So please, spend hours and hours practicing. Every patient with chest pain, have a look. It's important that they understand that this is practice. It's not a proper echo. You're just looking for a few things, and it's for your training. But when you get that hypotensive peri-arrest patient, it will make a huge difference. And in fact, this has revolutionized all of our practice, as you've more than realized by now. That's it. Let's get to scanning.